So thank you very much. Good morning. I'm very glad to be here today to share our first results related to this project that we have called Immunoaspect. This project is focused on another pathogens that we really didn't hear in this meeting because it's a bit difficult and a bit underestimated pathogens. This fungus in this project is focused, in fact, in Aspergillus diseases. Everybody may know that Aspergillus spores are continuously inhaled, and in normal lungs they do not induce any kind of pathology. Probably because of the, most probably because of normal neutrophil count, barrier integrity. So usually, and also recently, interestingly, it has been demonstrated that human-produced antigen-specific T regulatory T cells specific against Aspergillus spores in order to tolerate and balance the inflammation against this non-pathogenic fungus. In immunocompromised individuals, like for example in chronic granulomatous disease, in other immunodeficiency disease, there is a loss of the neutrophil count and also loss of barrier integrity, and this would lead to germination of this fungus, invasion, invasive aspergillosis, and activation of human antigen-specific Th17 cells, which collaborate to induce a very chronic and strong inflammation. But in cystic fibrosis, which is the context that we are interested, of course, in cystic fibrosis, there's a major complexity. When cystic fibrosis patients inhale spores, that will be, of course, a change in terms of barrier integrity, a low airway clearance, a high bacterial colonization, as we saw this morning, and it has been described the activation of human antigen-specific Th2 cells. The activation of Th2 cells would induce, finally, a very bad situation. So cystic fibrosis patients would set and would be more predisposed to establish a kind of allergic asthma, which is called allergic bronchopulmonary aspergillosis. It is a rare condition in a rare condition, so only 2 to 20% of people with cystic fibrosis would develop ABPA. So there's a profound lack of clinical study in that condition because of the rarity of this population, but also because clinical manifestations, like you can see, wheezing, fibrosis, bronchiectasis, are completely overlap with clinical manifestation of cystic fibrosis. And thanks to the sort of consortium group in cystic fibrosis and fungal infections, last year, it has been published new guidelines for management of these conditions. And then basically they conclude that there's a very strong emergency. I mean, in cystic fibrosis, we need to understand whether there are other kind of diagnosis markers, because there's a very high need of diagnosis and also timely diagnosis emergency. So in cystic fibrosis, you need to diagnose earlier these allergic conditions, because then this can deteriorate the pulmonary conditions already established in cystic fibrosis, and also they can be predisposed to other kind of allergy and to other kind of allergy against other fungi, which is called, in fact, ABPM. So not only due to Aspergillus, but also to other fungi. And in this regard, in the last years, new biological drugs have been also used in these conditions, like monoclonal antibodies neutralizing IgE, IL-5, and IL-4. And this is because, basically, of the lack of studies. A lot of studies just focus on the pathogenic mechanisms known, which is the expansion of human Th2 cells. But since my group of research and my background is also focused on Th17, and as we heard yesterday, in chronic in cystic fibrosis, there's a chronic activation of human Th17 cells and also pathogenic Th17 cells. we thought to understand whether this activation would impact in terms of ABPA settings. And therefore, we decided we were very encouraged to build a clinical study in this regard. So we wanted to build a clinical study where we include children between 5 to 21 years old, where there is an early diagnosis of ABPA. And during this clinical study, we isolate PBMC, serum plasma, and then hypopharyngeal aspirate every 3 months. So this is just a slide that was built at the beginning of the study. And then another important point is that we didn't finish to recruit all the patients because it's a very long process. And we would also include next year another cohort coming from London, so from the international partner. In this first scenario, we basically understood that, in fact, in terms of IgE, which is a diagnostic marker normally used in these patients, we can actually stratify patients on the basis of levels of IgE. So there are basically 0 levels of IgE against Aspergillus and cystic fibrosis, then a medium level of IgE in patients sensitized to Aspergillus, and a very, of course, high level of Aspergillus, of IgE specific against Aspergillus, as well as total IgE. And another thing that we got the point is that there is this fluctuation during the years, but also in 1 year also, of different IgE production, because, of course, of exacerbation phases of the disease and remission phases. So we thought to stratify the patients in this way, and also, on the basis of what we found in hypopharyngeal aspirate, we also are able now to stratify patients on the basis of cytokines produced in the hypopharyngeal aspirate, because we noticed, and this was actually unexpected, that in ABPA patients, there's a low reduction of production of IL-1 beta. So apparently, they have a reduced inflammation, which is the canonical inflammasome-mediated inflammation in patients. And this is perfectly also correlated with a change of the microbiome in terms of lung aspirate, because instead of having a chronic colonization of Pseudomonas, they have a chronic colonization of Staphylococcus aureus. So basically, the lung of ABPA patients is completely different in terms of microbiome and in terms of also of inflammation. By taking PBMC, we started the measurement of some immunophenotype and cytokines in order to understand how to further stratify patients. And another important step is that we noticed that they have a lower neutrophil count, there's a switch of B cells in sensitized patients, and an increase of memory T cells. But the most important step that we got so far is that that we realize that there is a precise ABPA cytokine signature that you can find easily in plasma just by normal ELISA test, but this was never found and never studied probably in ABPA patients. As we can see, this cytokine signature is only present in ABPA patients, and it's basically dominated by IL-17F, IL-22, and IL-23. So we were expecting somehow IL-17F, as we were mentioning before, because it is already established in other allergic patients, but never in cystic fibrosis and never in ABPA. The majority of the most prominent expressed cytokine is IL-22 in peripheral blood, and is also apparently increased in sensitized patients. There's, of course, a perfect correlation with IgE. So patients with IgE very high, they produce IL-17F, IL-22, and IL-23. Then we isolated also, in this first part of the project, we isolated Aspergillus form for clinical patients. We understood whether there were differences between wild-type strains, and this is partially overlapping the wild-type strain, and we use this to stimulate, again, PBMC coming from sensitized NABPA patients, and we see, again, the same cytokine signature, IL-17F, IL-22, and IL-23. Another important step that we are doing so far during the recruitment of these patients is to measuring subclasses of IgG. And we measured, and we got the point that an inverse correlation is present also in IgG4. So if you measure IgG4 specific against Aspergillus, this is only present in patients with no IgE. So we can say that if they produce IgG4, probably they would never be sensitized against Aspergillus. And this IgG4 is very important, actually, as was reviewed recently, when allergic patients, they have been pushed into switching the isotype toward IgG4 instead of IgE. IgG4 would compete with IgE, and this is very important in terms of neutralizing allergy and so reducing hypersensitivity. So by searching in literature, we were trying to understand whether someone else would, in the peripheral blood, have already described this signature. IL-17F, IL-22, and IL-23 were already described in PBMC in a nice paper published already 10 years ago, where this author mentioned that this signature is only present when there is a collaboration, let's say, a co-culture between B and T cell. They demonstrated that when you have B and T cell in co-culture and you stimulate directly B cell, there is this activation of this signature. So we basically build up our preliminary scenario. So basically we think that in cystic fibrosis, because of the mucus thickness, probably the phagocytosis of Aspergillus and the uptake by epithelial layers is for sure reduced. This would probably induce a direct B cell activation, which will lead to T cell to produce IL-17F and then IL-22, and of course they would respond to IL-23. This is impacting a lot, and this we know because a lot of receptor for IL-17F is present in epithelial lung cells, and this would probably polarize for Th2 specific cells and then isotypic switch towards IgE, and then therefore predisposed to allergic asthma. We also have data related to the source of IL-17F. So we believe that part of the IL-17F is also coming from innate lymphocytes type 3. And so for this, we want to, I would just conclude by saying that if we take this scenario, we would hypothesize a novel kind of management preventive, clinical preventing for pediatrician patients. So let's think about a pediatric patient with some clinical manifestations of ABPA, so some allergic manifestation. In this case, usually what it is done is the measure of IgE. But we would suggest also to look at the microbiome in presence of Staphylococcus aureus and also in presence of negative IgG4 specific for IgE. Probably there is also this signature in peripheral blood, which is easily and very, very economically speaking, very easy to determine. And then this would say that the child he's probably going into the sensitization step, and then this would then bring to the asthmatic scenario if nothing would change in terms of therapy. And with this, I have to thank, first of all, my PhD student, Gianluca Vascelli, because he was putting all himself in this project completely. And so I have to thank, first of all, Gianluca, and then the delegation of Cystic Fibrosis to Support, and then the Hospital of Bambino Gesù and Hospital of Cerignola, because the two cohorts are contributing to this work. And thank you for your attention.